Good evening, good afternoon, good morning, everybody. Very warm welcome to all of you joining us to this journal club by the International Academy for Clinical Hematology. I'm Mohamad Mohty from the Sorbonne University in Saint-Antoine Hospital in Paris, in France. It is 7 p.m. in Paris, 1 p.m. in Toronto, 8 p.m. in Jerusalem. And it is my great pleasure to moderate this monthly journal club. So the Scientific Steering Committee of the ICH has selected recently this paper published earlier in February 2025 in Blood Advances, entitled PTCy-based graft-versus-host disease prophylaxis for matched sibling donor allogenic hematopoietic cell transplantation by Dr. Nihar, Desai, and colleagues. And we are very fortunate, privileged, and honored having Dr. Desai himself with us as a panelist for this journal club. The other panelist who is not co-author of this paper, who is a top expert in the field of transplant, and this is the famous Professor Arnon Nagler, who is the vice chair of the ICH. So this is a large series of 413 patients who received transplant from matched sibling donors, single center, relatively long period, 2010-2023. And the authors in the single center series managed to identify over time 4 groups where their GVHD prophylaxis practices have evolved progressively from the classical calcineurin inhibitor methotrexate, the historical TAC methotrexate or cyclosporin methotrexate, then CNI methotrexate or MMF plus ATG, also a combination that is well established. And then another 2 groups which are more recent, and this is about the advent of PTCy for GVHD prophylaxis plus CNI and MMF, or even pushing it a little bit further, combining PTCy and ATG plus calcineurin inhibitors. And of course, the goal of the work in this specific setting of matched sibling donor, which is quite unique because obviously ATG has been made popular mainly in the matched unrelated and mismatched unrelated setting, whereas PTCy has been initially developed in the haploidentical transplant. So nevertheless, based on this single center analysis, you can see here, this is a figure from the paper, the cumulative incidence of grade 2 to 4 GVHD, grades 3 to 4 GVHD, acute GVHD, comparing the 4 groups. We can also see the cumulative incidence of chronic GVHD, all grade or moderate and severe. And you can see the black curve. This is the historical control, CNI methotrexate, where this is where you have the highest incidence of any event. But then you can appreciate that with the use of PTCy, for instance, the green curve or the blue curves, these incidences are significantly decreasing. At the end of the day, when you look to the final outcome, whether overall survival, non-relapse mortality, but even cumulative incidence of relapse, for instance, with cumulative incidence of relapse, it doesn't look like there is a key difference. There are differences in terms of non-relapse mortality, with the best figures achieved with PTCy plus CNI MMF. And we can see the counterpart of this result showing in the blue curve the overall survival of the post-Cy advantage. But when we look into the ultimate, I would say, outcome, which is GRFS, graft-versus-host disease and relapse-free survival, then it looks like PTCy or PTCy plus ATG or even ATG plus CNI methotrexate are leading to similar results. So my personal conclusions when I read this work, I thought there are some great strengths there, very large series, 413 patient, very comprehensive, detailed comparison of strong GVHD prophylaxis regimens, and the results are really supporting what is well established now in the field, the use of PTCy as an effective approach in the matched sibling donor transplant. Obviously, some weaknesses there, the retrospective design, very long period, roughly more than 20 years, potential selection bias. We do have more bloodstream infections with PTCy. In this matched sibling donor setting, it doesn't look like that combining ATG with PTCy is a great idea, although it doesn't do any harm in the GRF when it comes to GRFS. But still, in contrast to the haplo setting, for instance, where it showed benefit in other series, here it's not clear. And of course, our follow-up is still relatively short. So here, again, thank you, Professor Nagler. Thank you, Dr. Desai, for accepting the invitation of the ICH to discuss this paper. And as usual, my first question will go to Professor Nagler to give his general thought and feelings about these results when you received this table of content of blood advances, Arnon, and you looked into this article. What was your reaction?
So thank you, Professor Mohty. First, to congratulate Dr. Desai for this important paper. I think the paper is important because we all know that PTCy revolutionized the anti-GVHD prophylaxis, which is still the main non-relapse cause for non-relapse mortality. And if you look on the CIBMTR data, not just in haplo, more than 95% of the patients receive PTCR, but also in sibling, it's about 25%. And for MAD and mismatch unrelated, for mismatch unrelated, it's 70%, for MAD is 25%. So, you know, there is a lot of excitement, rightly, about PTCy in haplo that revolutionary reduced transplant-related mortality and improve results, reduce GVHD. However, in the sibling transplantation, it's always question if PTCy is better than ATG, and as you know, your team, Eola, Professor Briost, and yourself did some nice study in the acute leukemia and also a randomized study of the 40 patients each arm, comparing PTCy and the ATG, and the official recommendation of the EBMT consensus paper do not recommend the PTCy in the sibling transplant, and they say that in sibling transplant is no data for PTCy, while in the mismatch unrelated and unrelated, it's either PTCy and ATG, and the haplo is a PTCy. So I think that this paper is important to see the role of PTCy in sibling transplant. This is number one. And number two, the combination. Your team again published and other published that with adding ATG, you can reduce the doses of PTCy and then reduce some of the disadvantages of PTCy, slow engraftment, late infection, viral reactivation, and cardiotoxicity. And so the question is, should we add the PTCy to ATG? And the paper supports the notion that at least in sibling transplantation, there is problem when you add with increased CMV and EBV reactivation and not a great advantage to it. So I think that this paper is important. Then you rightly, there are, of course, this is not randomized study, and we all preach for randomized study, but it's after I guess 15 years or 10 years of PTCy in haplo from the Baltimore and so on, we still don't have big randomized study, and for sure not in sibling transplant.
Thank you very much, Arnon. So now my question to you, Nihar, maybe to explain to our audience what was the rationale behind this sequential approach of modifying your GVHD prophylaxis regimens over time?
Sorry, Professor Mohty. I think I lost the connection there.
So my question to you was about maybe to explain to the audience of the ICH Journal Club, what was the rationale for modifying your GVHD prophylaxis regimen over time, especially in this matched sibling donor, where the community, as mentioned by Professor Nagler, thought that we do have a sort of an acceptable reference, historical, well-established prophylaxis approach.
Thank you. Before I start, I'd really like to acknowledge and I'm thankful to be here and to take the question. So this was a series of patients collected retrospectively over a period of 13 years at a single center, like you well summarized. In 2010, like all of the centers, the standard was pretty much calcineurin inhibitor and methotrexate or MMF. And that remained the standard until 2015 or 2014, something of that sort, when it was seen that though acute GVHD was not a major concern, we did see significant rates of moderate to severe chronic GVHD. So the institutional standard evolved, and it was thought that maybe we could try combining ATG at the time. So that led to the second group in a bid to reduce the incidence of chronic GVHD that was really troubling the patients. Well, that was just 34 patients. And then in 2015, again, institutional standards evolved with the use of PTCy, and it was decided that across all donor types, we could do a combination of ATG and PTCy along with a calcineurin inhibitor. And this is the 78 patients that were treated because that was the institutional protocol. But on review, we noticed that the rates of CMV reactivation and EBV reactivation were unacceptably high. So the initial bid in the haplo setting in our center was to go down, in the sibling, in the unrelated donor setting, was to try and drop the dose of ATG. So the change was successfully made from 4.5 to 2. And then eventually it was, as rightly pointed out, everyone believed that it was an overkill in the sibling setting. And so the final group evolved from 2019 onwards, where the consensus was that we would use PTCy in the siblings, but omit the ATG, given the exceptional high rates of EBV and CMV that we were seeing with the combination. So 2019 to 2023, the standard has pretty much been PTCy for all donor types, but for the sibling donors, we've excluded ATG, and it's now a combination of PTCy, CNI, and MMF, which is what the Institute is currently using for sibling donors. And the goal here was to find a delicate balance between improving the GRFS and at the same time making sure that the viral reactivations are not prohibitively high. So this is how the evolution happened over a period of 13 years.
Excellent. Thank you very much. And again, congratulations for, I think, and this is important, and a key message to all of us is always, whatever we do, try to analyze our practices and try to draw conclusions to continue to improve. And this is, I think, a message that is extremely important to the field. So Arnon, based on these results, the conclusion was PTCy looks very good in the sibling donor, but here it is combined with CNI MMF, and we have many colleagues who tried actually to substitute CNI MMF or CNI methotrexate with PTCy alone, especially in the masked sibling donor, because obviously we want to try to get rid of the side effects of the calcineurin inhibitors. And also, my other question, which is coming also from the audience, is about whether all of this would have been different if we have used bone marrow, unmanipulated bone marrow, compared to the popular PBSCs.
So, transplant is a puzzle. So, of course, if you change the conditioning, here it was about half-half when it did myeloablative and reduced intensity, but most of the patient, 80% received TBI. So, of course, in transplant, if you change the conditioning or change the graft, then it's a different story. We know that most of the studies that look on GVHD prophylaxis, at least in the modern area, look on peripheral blood because there is higher incidence of GVHD with peripheral blood and with reduced intensity. And therefore, most of the recent study are attacking or focusing on this population. So if you do bone marrow, you have less GVHD, but you have other problem like increased risk of relapse and maybe even engraftment. So I think that I'm not sure that the results would be the same with bone marrow. As for getting rid of the CNI, I'm not sure that that we can do it. PTCy alone, even in the haplo setting, did not work well. So in all the study of the CBMTR, and there are 3 randomized study with the CBMTR that include PTCy, when the most popular is the 1703, in which they compare MMF methotrexate, MMF tacrolimus and PTCy to methotrexate and tacrolimus, and they omit ATG, and they found out that the severe acute GVHD and chronic GVHD is reduced with PTCy, and GRFS is better. But when we, in the acute working party registry study, so it's not a randomized study, nothing to compare to 1703, when we add ATGs to control groups, we didn't find this different. So I would not go for omitting the CNI. I don't think we are this. Methotrexate is another story. We know that methotrexate can cause mucositis and slowing the engraftment. So we all try sometimes to replace MMF. You tried it, our center tried it. It was not too successful, at least in our hands, replacing the methotrexate with MMF. So yes, with bone marrow, it can be different. But I think that there are no data for, the PTCy. Both PTCy and ATG are better than on the other without them in sibling transplant, but I don't think that we have strong data or can recommend PTCy in sibling transplant like this paper also advocate for it. This is the previous literature and also support very nicely by this study.
Thank you, Arnon. And I think Dr. Madney is in agreement with you, highlighting that we need cyclosporin plus PTCy, especially in peripheral blood, but the use of PTCy allow for rapid withdrawal of cyclosporin. Here, Nihar, we have a question from Dr. Koman, who works here in Paris. Whether you have analyzed separately those patients who received the myeloablative conditioning versus a reduced intensity conditioning, and whether your conclusions are relevant for both conditionings.
Thank you for the question. So yes, I completely agree with the CNI bit as well, because early tapering was seen even in our study. I mean, the median was somewhere around 120 days without the PTCy, and with PTCy it was around 89 or 90 days. So it does give us an opportunity to reduce the exposure to CNI, but I don't think we're in a position probably right now to comment if we could completely do away with the CNI. And yeah, for the second question, no, we did not actually look at the 2 subgroups separately. again, because of limited numbers in the other subgroups, like the ones who received ATG, CNI, MTX, that was a very small group with just 34 patients. So we decided that we wouldn't be able to offer meaningful conclusions if we performed that analysis with the RIC and MAC subgroups in addition to what we already did. So unfortunately, this paper, we didn't look at the conditioning regimen intensity.
Thank you. One question, and maybe Arnon, you can handle this, from Dr. Tugrul Elverdi about the value of abatacept, because abatacept has been approved for GVHD prophylaxis in the match unrelated setting. I don't believe it's widely used, but obviously there are some speculations about its value. And here the question is, in Nihar's paper and series, it doesn't look like ATG plus PTCy are the best combination in the match sibling donor. What about abatacept and PTCy? Any thoughts on this?
Yeah, so as you rightly say, I mean, in the States, there was a big hype, I would say, with abatacept. It was even a plenary in one of the tandem meetings, I guess 3 years ago. And they did a few studies, and usually, I mean, it's reducing more the acute GVHD, less of the chronic GVHD. We just talk now about, the long-term immunosuppression. And there are some, the second paper says that abatacept abrogate the importance of HLA because the result with mismatch unrelated transplant with abatacept was similar to a MAD transplant. By the way, Georgia from Acute Leukemia Working Party did similar study in the ASH showing that PTCy with mismatch MAD is like it's like MAD. And so they are trying to, this was the title, abrogating the importance of HLA. It doesn't work about chronic GVHD. We are not using it too much in Europe, but in haplo settings, there is a study in which they use the combination of abatacept and PTCy and I guess tacrolimus. This was an oral at ASH, and a small paper was published. And I think, the preliminary results look very nice. And this combination is an attractive one, I would say.
Work in progress.
Because PTCy is the chronic GVHD and abatacept is the acute GVHD, and combined together, you have both against acute and chronic. And so it's an interesting combination. Yeah.
Thank you, Arnon.
But we don't have experience in this. This is just from the literature.
Thank you very much. So Nihar, we have a few comments because in the conclusions of your paper, you have emphasized the issue of CMV reactivation. But then here people are advocating that now at the era of letermovir, CMV reactivation, irrespective of any GVHD prophylaxis you're using, is not a matter of concern. So how was it for the use of letermovir in your practice? Is it because of the lack of letermovir that you started seeing all of these CMV reactivations?
Yes, so we did see quite a few CMV reactivations, especially as we've said in the paper in the results. The combination led to exceptionally high rates of CMV. And it's important to know that this combination that we were using was before the universal approval of letermovir. Post-letermovir, in the era of letermovir, the approval in Canada is for patients who are CMV seropositive, receiving either a haploidentical transplant or receiving ATG. So most of our patients who received PTCy did not receive letermovir. We had only 15 patients in the whole cohort who received letermovir. So there were two reasons, one being that it was introduced at a later time point, and the study included patients from 2010 to 23. And the second being that it was not approved for the use with only PTCy, even if the patient was CMV seropositive. So it was the Health Canada approval states that the patient should have received ATG in order to be eligible for letermovir. So we had very few patients who received letermovir, just 15 patients in the study. But despite this, our rates of CMV, as I said, were pretty high in this study. We had 42% reactivation with the combination and close to 20% with PTCy, CNI, and MMF. But thankfully, with improved practices, this is not translated into any end organ damage, but the rates were sitting pretty at around 20%.
So let me stay with you, Nihar, because we have also a few questions, because your conclusion regarding the combination of ATG and PTCy didn't prove to be better than PTCy alone. It wasn't inferior, but it wasn't better. So several questions we have is about the ATG brand and the ATG dosage, because obviously the devil is always in the details. So can you just clarify what did you use? Because when I read the paper, actually in the patient and methods, it looks like to me that even the schedule of ATG has been changing over time in your center, correct?
Yes, that's a great catch. So yes, so the brand has always been thymoglobulin, and the dosing changed somewhere between 2017, and this was in keeping with some publications that we did from our center at the time, that with 4.5 milligram per kilogram of ATG, the CMV, the EBV reactivation was really high. It was in the tune of 60%. So the dose was then dropped to 2 milligram per kilogram. So 0.5 and 1.5 on days -3 and -2. And this is what was used in 3/4 of the patients who received ATG, and 1/4 approximately received the 4.5 milligram dose. Again, because of the small numbers, we couldn't tease out the differences in outcomes and the reactivations between the dosages. But in the other settings of MUD and haplos, dropping the ATG dose has led to significant reduction in the EBV and CMV reactivations in our center. So even for MUDs now, our standard is thymoglobulin 2 milligrams per kilogram. And for haploidenticals, we still use 4.5 milligram per kilogram along with PTCy.
Thank you very much. That's very clear and important. So now a few questions to you, Arnon, because obviously Nihar told us that PTCy is now their standard of care, and I believe many centers are very excited about PTCy, not necessarily in the matched sibling, but in general, there is a sort of a wave of enthusiasm around the use of PTCy across the transplant landscape. But again, in order to be fair and balanced, for me, there are some inconveniences associated with the use of high dose PTCy, at least a 100 milligram per kg total dose. Can you just elaborate on this, Arnon, because you also analyzed some of these data in different papers?
About the dose of PTCy?
Yes, I mean
Yeah.
the side effects of PTCy. What are the inconveniences? Can you use PTCy 100 milligram per kilo in everybody, in any circumstances, any age? I mean, that is a question.
Okay. So first of all, we didn't mention, but congratulations again. There is a commentary on this paper in Blood Advance. And in the commentary, they also discussed the thymoglobulin versus Neovi or Fresenius ATG and claim, I'm not sure, but at least that with ATG we can stop, with Fresenius or Neovi, we can stop immunosuppression earlier. So the branch of, as we know, and you published many years ago, the nice review in leukemia and other, that the dose and branch of ATG is very important. As for the PTCy, of course, cardiotoxicity is a problem, especially in patients that are above the age of 65, but most of our patients now in all the centers with AML, MDS are above the 65, and in patients with cardiac comorbidities. So, I mean, you and many others are reducing the dose of PTCy to 80 milligram and now to 70 milligram, and they are in ASH, there was a study from China and others that they reduced the PTCy to half a dose by adding ruxolitinib. This is upfront from both CIBMTR studies and also from China. So I think that, as you know, thanks to the Baltimore group, Brian Kuches and Leo, I mean, with the PTCy, but this was not a very, kinetic, thorough studies, and now many centers are going back for the PTCy. Of course, hemorrhagic cystitis from day one of haplo was a major concern in the PTCy, and then the infection and later activation of CMV, and also, the nice studies about the reconstitution of the immune system with PTCy, that in the first month we have knockdown of the NK alloreactive T cells and the higher T regulatory cells, but also a subset of reduced precursor of cytotoxic T cells against, and the fear of the relapse rate. But in this paper, and we also published last year in American Journal of Hematology from Acute Leukemia Working Party and other, there is no higher relapse rate with the PTCy. So I think that we are also trying in our department to reduce the dose of PTCy, whether you need to add ATG or can do it alone. This is the question, and again, it depends on the type of the donor, the type of the graft, and the matching of the HLA. So it's always a combination.
Thank you, Arnon. So Nihar, in your practice today, are you able to deliver POSI universally, or you're tempted by some optimization in some subgroup of patients? What is your current dosage and practice, and how do you use it actually?
Thank you. Yes, certainly. I acknowledge all of those limitations. I mean, they are very well known. The cardiotoxicity has been a concern. Just sticking to this paper, we didn't see any deaths because of cardiotoxicity, but I'm sure that we did have some transient LV dysfunction that was seen, although the data was not presented, and we are further analyzing this cohort. So we have now, since you asked about the practice, in the setting of matched unrelated donor transplants, and because we have the luxury of using the combination for now, and I say luxury because then we were a bit less skeptical in reducing the dose. So we've initiated a pilot, and now, especially we started with the MUD setting, and we've dropped the PTCy dose to 70 milligram per kilogram, so 35 milligram per kilogram on days 3 and 4. And the results seem very promising. We've sent out some abstracts, but it's not yet published data. But we did see a significant reduction in the bloodstream infections and the other toxicities as well, and a slightly earlier day of engraftment as well for the neutrophils as well as for the platelets. So certainly promising, and we don't have long-term data with the reduction in dose, so can't comment on the chronic GVHD rates yet. The acute GVHD at day 100 was not significantly different compared to the 100 milligram per kilogram group.
Excellent. Thank you very much. So now I have a couple of last questions. So one question to you, Arnon. How do you see the field of GVHD prophylaxis moving? And based on this work, based on other published works in this field, what would be the studies that you would love to see or to do in order to further optimize our GVHD prophylaxis?
I would say that after many years with no progress in GVHD, I will talk now acute and chronic, because the chronic, 70% is from acute GVHD. So the field of GVHD is really, for the patient and for us, it's really now, I would say, blooming, with the 3 approved drugs in chronic GVHD and many approaches and many studies. I would say that we are now in the microbiome and fecal transplantation and many other studies that are many new molecules and so on. I think that the field is, the when we do and look if overall in the population GVHD is reduced or the results are improved a bit, but less than we would like to expect, and this is because we are transplanting more and more patients with comorbidity and elderly patients, and therefore this we cannot see the real, maybe revolution, I would say. This is a provocative, but improvement in the GVHD prophylaxis. We all say in all our talks that, but most of the studies were done before the era of the PTCy, and we hope that with PTCy, the incidence of GVHD will be reduced, and we need to repeat some of the studies, to see if it's also true in the era of PTCy. So I think that some of the studies with new molecules and the other approaches like fecal transplantation and other should be done now in the setting of, I would say, mismatch transplant, because the major problem is in mismatch transplantation and unrelated transplant. I would say less so in haploidentical transplant and in sibling transplantation, and also the majority of the patients that go transplant in most of the centers are unrelated. Let's put it this way, although there are centers in the world that moved completely or mostly to haploidentical transplant. So I would say that we need to study the unrelated setting with a PTCy backbone, and then if we can improve and lower down the GVHD without increasing the relapse, with improving of GRFS and overall survival with some new approaches or new molecules that are around.
Thank you, Arnon. So one last question to you, Nihar. So if I'm willing to give you a $10 million grant today, what kind of studies of GVHD prophylaxis would you design? Because you would be really convinced that this will make a big difference in the life of patients.
That's a huge amount.
Well, okay. Well, take 5 million. I mean, we can keep 5.
No, I'm happy with the 10. So certainly, I mean, convinced with the PTCy backbone, but probably something to look at if we can reduce some other agents and optimize the combination across donor types. So just why stop at one, maybe run 2 trials in different donors so that we reduce the heterogeneity, because many a times it's the problem in transplant is that there are so many moving parts and variables that randomized trials cannot really answer all of that if they have to robustly answer it. So maybe design 2 in different donor settings and see what the optimal combination with the PTCy backbone could be. Could be combining with the abatacept, as Dr. Nagler pointed out. Reducing the CNI would be something, because that is, I think, of the 3, optimization of PTCy, yes, that could be done, but certainly a better combination strategy could be explored. So maybe eliminate the CNI and try something else with the PTCy backbone to optimize it. That would something I would consider doing.
But also,
wonderful. Yeah.
Also,
please.
one word that I forgot is the elderly patient. So we are transplanting more and more elderly. So the study need to be in elderly patient. Because there we have the major problem with GVHD and transplant toxicity. So yeah, elderly patient above 65.
Certainly.
Well, thank you both for really lovely and exciting discussion. Although we may not have solved the issue of GVHD prophylaxis in the matched sibling donor with all of these new available options. However, I would like to congratulate again Dr. Desai and his colleagues for publishing this paper in Blood Advances, and it presents valuable insights into GVHD prophylaxis, and that contributes to the evolving strategies for improving transplant outcomes. I think our discussion and the conclusions of the study highlight how difficult it is actually to combine both an optimal GvHD prevention and optimal immune reconstitution, trying to keep with a good final outcome at the end. So it's a moving field, and when we modify one parameter, all the others are going to change. But I feel that as the field continues to refine these prophylactic approaches, the work from Dr. Desai and similar other works offer a foundation for further research and clinical application. Thank you all for the engaging discussion. Thank you all for sharing questions. I do apologize. We were, as usual, we're not always able to take all questions, but I'm sure you can reach out to Professor Nagler and Dr. Desai by email. We look forward to next month's journal club, which will be dedicated to a very exciting paper published in the Lancet Hematology, actually in the field of multiple myeloma. But at this time point, I'd like to thank you all again for your loyalty to the International Academy for Clinical Hematology. And wherever you are, please stay safe and keep well. Thank you very much.
Thank you once again for the invite, Professor
Thank
Mohty.
you.
Thank you, Professor Nagler.
Thank you. Congratulations.
Thank you.
Bye-bye.